my beard. It might get even colder.
It's like a store-bought.
Did everyone have a good weekend? Did anyone do something fun this weekend?
No.
What did you do?
I went skydiving.
No.
You went skydiving?
For the first time.
Oh, wow.
I know some of these people have done it 1,000 times, but they've added.
Okay, we have a skydiving. What else did you do? You went on a date. That was lovely. I love that. One more. Something fun.
Put together a top. Put together a top.
That's not true.
That wasn't fun.
Oh my gosh.
It wasn't 100 degrees.
Okay.
What about you? You tell us.
That's why I'm like, right there. I did. It's not that. Okay, if we are thinking back into the pediatric mindset, the last one we talked about was both the growth and the development of the kiddos, and then how the different things for the well visit. So when we're thinking about that, at what age do you get a screening lipid panel for all children? All children. The lipid panel. 9 to when? 9 to 11. So that's the universal screening. Who got it at 2? That family history where mom or dad had cholesterol over 240, or there was an early CAD. At what weight do you give neonates immunization? So let's say you had a premature neonate. Yep, 2 kilograms. Remember, when in doubt, guess 2. If a child has an egg allergy, can he or she still get a flu shot?
Yes.
What about if they've had anaphylaxis to a previous shot? No. Okay. What temperature should the water heater be set for children? Music to my ears. Thank you. At what age do you need to avoid fluoride toothpaste until?
2.
Don't worry about it.
Yes, correct. You don't need to avoid fluoride toothpaste. Trick question. Okay. At what age do infants sit? Sit up. 6 months. Yeah. Sit at 6. Yep. At what age do they babble? 6 months. Yep. Yep. Babble has 6 letters. At what age should you be able to put 2 words together? Go outside. Want more. 2. Yep. If you are concerned for a language delay, what 2 specialists do you need to refer to, and what order? Audiology, then speech. Good. Okay. Let's review. So, we said, what do you do when this baby is born? What do we even call a baby? How do those neonates in those first 28 days get sick? What happens to them? Okay, what about the rest of these kids? What is normal growth and development? So that was that first half. That's the first half of block 1. What is all those normals? This starts to talk about what happens when they're not normal. So what happens when things go awry? So you do the well visit, you're doing all of the education, you do all those pieces, and something's not normal. So that's where this lecture goes into. It is all the exact same words. I got a little crazy last night with underlining and bolding, so it's the same exact PowerPoint with like more bolding. Okay, so when we talk about failure to thrive, so that's the first thing. Then I know there are some different words because I was reading over the weekend and they have changed the terminology on us once again. So your textbook and what you guys will still be responsible for on pants will be called failure to thrive because they just changed it. But the new definition, when you're in your phase 2, I just want you to know what that is going to be called growth faltering. So those are the same things. So failure to thrive and growth faltering, same exact things. And that functionally means that you have a young infant, so we're over the age of how many days?
28.
Yep, we're over 28 days and into those young child, so it could be a toddler, it could be a young school-age children, who are failing to meet what we expect with growth. And particularly, we're talking about weight here most of the time. It's usually a contribution of a whole lot of things. So yes, sometimes it's just medical. Sometimes there's just things in the environment or in a home setting. But most of the time, there's multifactorial things going on. So when we're really breaking this down, we're looking at what is the cause. 2/3 of the time, it's not some organic disease that's going on. It's something to do with, on one side of the spectrum, they are being abused and malnourished from that. On the other side of the spectrum, it's complete ignorance. The family that didn't know that breakfast, lunch, and dinner was not correct, right? That was that whole spectrum, yet the baby still comes in failure to thrive or growth faltering. 1/3 of the time, you're actually gonna see something underlying that's going wrong. So think about celiac disease. They come in, they're really, really small, they're not growing as expected. Oh, we have a definitive cause that we can correct. So that's only gonna be about 1/3 of the time. How do you define this then? So you're defining it as, and you see two things there. You say as less than the 3rd or the 5th percentile. So let me explain this. When we talked about BMI for a normal child, what was those ranges?
5 to 85.
5 to 85, right? So then we said, well, that kind of makes sense if we then use the 5th percentile of weight to say what a normal is, a normal child's rate. But then they said, but what about if we use the standard deviations? That takes us to the 3rd. So there's a whole bunch of pediatricians that debate over, is it the 3rd or the 5th? Ultimately, don't worry about it. I'm not going to give you something that's the 4th percentile and ask you what to do with it. I will give you somebody that's in the 0th percentile or the 10th percentile, something like that. But just know there's some of that out there. Typically, I will use the 5th because that makes the most sense to me. The other thing that you can see, so you only need one of these. So either you're at the very, very low end of that growth chart, or you've crossed 2 of those percentile lines. So we already talked about that one. And then probably the one that we use the least, but remember we said there was weight, length, head, or BMI if you're older, and then that weight for length that looks at how proportional you are. So if you're less than 80% of the median weight for height, that is your 3rd definition. So probably use that one the least of all of them. And then we're gonna make sure that we've adjusted for prematurity. And prematurity for birth is defined as how many weeks or less for our purposes? Yep, so less than 37 weeks, we are going to give that. So what do we adjust for? Do we adjust ASQs? Ages and Stages questionnaire for prematurity?
Yes.
Yes.
Yes. How much prematurity? More than a month. So if they're more than a month premature, we adjust those ASQs. Do we adjust immunizations for prematurity?
No.
No, the infectious disease didn't get the memo that they were early. And then the last thing I will say about this is that we do this holistically. If there's one point in time that doesn't make sense, probably operator error, let's recheck. If they're growing as a whole, we're looking at that. So we'll take a look at some of these charts to look at that today. And if it's organic or non-organic, ultimately we start thinking about the physiology of what is going on with this child. And so at some level, we don't have enough nutrients to meet the demand. So could that be because we're not intaking enough? That's one of the options. Is it breakfast, lunch, and dinner? Are they watering down the formula to make it last longer? Does mom not produce enough breast milk? A lot of different reasons why you could have not enough calories. Or are they unable to absorb them? So when we think about, are they just having, as soon as it goes down, are they throwing it back up? Are they having inflammatory bowel disease and it's not able to be absorbed? Celiac disease, so some sort of process is going wrong with the absorption. Or do they just need more? They have VSD, they have some congenital heart issue and they need more than the average kiddo. So somehow one of those 3 options is not happening. We further subclassify this into what is going on. We talked about this the other day. The first thing that's gonna go is your weight. So you're gonna get really long and lean and your head's still gonna grow, but you're gonna be wasting away. So type 1 is wasting. Have you ever gone home and your mom's like, you're wasting away? You lost weight? That's type 1. So the length is preserved, your head is preserved, but you don't have that weight. Type 2, if you think about that and you go home and you're really, really short and they say you're gonna stunt your growth if you don't eat everything on your plate. Well, that is when your height is affected. So now your weight and your height is affected. Your head is still maintained. Usually this is months long of this malnourishment. And then type 3 is when everything is affected. So your weight, your length, and your head is affected. And this could be a couple of reasons. One, this could be severe, prolonged, chronic malnourishment where all 3 have been affected. Or you could see this more often with chromosomal abnormalities or some sort of genetic anomaly where the child overall is just symmetrically a lot smaller. We'll talk about several of those today. So this would be an example of a growth chart where the child has failure to thrive or growth faltering. So now that I have my pointer, let's use it. So we look at this top child. So the top child is child A. Child A came in, they started in that, 75th percentile, and every single time they come for those well visits, they continue to march right along that 75th percentile. That is truly a perfect growth chart. If you saw that, that child is holistically doing exactly what we want them to do with weights. You see this child, child B, down here. So they started in the, 25th percentile, way down here, around that one. They come in for their newborn, they come in for their 2-month, and then for some reason they come into that 3-month well visit. So at this point, they really haven't quite crossed one line, maybe one line, but you've seen that trajectory of that growth really slow down. Okay? So it slowed down. I'm like, okay, maybe it'll bounce right back up. Maybe it'll continue to go down. We see this. At this point, now they've crossed over one line and now 2 lines. So right here at that 4-month mark is where you should have intervened. That is where you would have made that diagnosis of growth faltering or failure to thrive. Right here, when they, oh my goodness, this is what happens when they give me a pointer. Right here is where you would have called that. What didn't happen there was that was never called. So this child continues to come for follow-ups until the point where they're about 8 months old. And at 8 months, what happened at 8 months? What happened at 8 months that's different from the rest of them? They lost weight, right? Is it ever normal for a baby to lose weight? No. So that was the point where we were like, whoa, okay, well, we didn't gain any, and now we're starting to lose weight. And so that is what finally prompted this to be called failure to thrive, even though we could have called it there 5 months earlier, okay? That is where you should have intervened. Child starts getting nutritional help and shoots right back up. What you do see is that that child missed that critical window from part of that 4 to 24 months, and so they are not able to catch back up to that 25th percentile. Now they are down in that kind of 10 to 15th percentile. So it channeled them to a different growth percentile, even though it is still appropriate, okay? So that's what I want you guys to be able to see, is if you see a growth chart, maybe not as pronounced as this, but at what point would you have called it? It's crossing 2 lines, they're down in the 3rd, 5th percentile, or they're starting to lose weight. And then what do you do? When do you intervene? Do you bring them back? Do you get them into feeding therapies? What do you do with these children? So one of the things you'll have to make that decision on is, where am I going to do this? Where am I going to intervene? I could see that they've crossed 2 percentiles, they're losing weight, this child is classified, my diagnosis is failure to thrive or growth faltering. But what do I do and where do I do it? Does that child need to go to the hospital, or can I do this as an outpatient? So that's question number 1, inpatient or outpatient. So the times where you would do inpatient, it's either super duper severe, and so you're like, what does that even mean? Well, if I'm looking at this child, this is a child that is severe. They have not gained any weight since they were 3 months old. They are now 8 months old. They haven't gained any weight in 2/3 of their life. That's pretty severe. They're losing weight. It's pretty severe. They have type 2 or type 3. That's pretty severe. So if you have severe malnourishment. If you have an underlying diagnosis where you are going to need additional workup that's going to need advanced imaging or being put under, a lot of times we will admit for that. So if you think about the child where we're going to do an endoscopy and a colonoscopy, and they're going to be sedated for several hours, we will often admit to expedite that workup. If safety is ever an issue, so if at any point you had thought along that route, ooh, there's abuse, there's concern that this child is not being fed at all, that would be an indication. So if ever safety is a concern, you can admit to do inpatient. Or if they failed outpatient, let's say this family, they have gone to lactation, they went to the dietitian, they went to GI, they've done all the things that you asked them to for follow-up, and they have failed outpatient, then you would admit also to get a better idea of what's going on. Because the hospitalization allows us to do their strict ins and outs. What is going in, how much is coming out, Let's calculate that to figure out what is going on with that child. Ultimately, most of this is going to come from the history. Had I asked an earlier history, I would have been able to see, oh, they're doing breakfast, lunch, and dinner. Shoot, I could have caught that on a history. So most of the time, this is going to be from a good history. When you do get them in the hospital, there's a couple of outcomes. So now they're in the hospital, you are controlling for what's going in, what's coming out, and being able to calculate that. So option number one, you go into the hospital, they feed great, they gain weight. Right? If you're 2 months old, how much should you be gaining a day? An ounce, yeah, 30 grams, 20 to 30 grams. So that you should be able to see that very easily over the course of a couple of days. So option one, you admit them, they gain an ounce that day, they gain an ounce the next day. And you're like, well, they're feeding fine. It tells you there's probably something going on with feeding or something going on at home because they're able to do it when they're in a very controlled environment. Option number two, they feed just fine and they don't gain any weight. What's going on? Then I start to think there's an organic issue, something endocrinologically, in the endocrine system, or some sort of inborn error of metabolism, something that's going on with them. So most of the time I think, is their thyroid okay? When in doubt, think thyroid. Or the third option, you get them into the hospital and all of a sudden there's choking, gagging, dysphagia, a ton of feeding issues, they're aspirating, right? So then that tells me, ooh, they actually can't do this correctly. And then we end up getting a different set of specialists on board. So those are really kind of your three options in what you're going to do if you are going to work them up. So that your history is so important. What happened before they were born? What happened in utero? What happened with birth? What's happened since birth? What are their poops like? What are their feedings like? How much? When? Right? The very detailed history of what is going in, what is coming out, what is going on with this family can be super helpful. Is dad deployed and grandma's come in and grandma's doing the feedings now and that's right when you saw that shift happen? Or did they just move and there's a new au pair in the house? All kinds of stuff happens with different social situations. Physical exam will be your full set of charts and your general impression. So if you go in the room, your general impression is your most important part of the exam for the most part because you get so much information. If you go into the room and you had seen these growth charts of this teeny tiny little kid, and you go in and mom is teeny tiny and dad is teeny tiny and the siblings are teeny tiny and the kid's running around the room playing, are you concerned? No. If you go in, mom and dad are pretty normal size and the kid is laying on the bed like, help me, very concerned. So my general impression gives me so much information for that. Certainly your head to toe exam is going to be helpful. What things might you see on a head to toe or while you're observing a feeding? So I might see while mom or dad is feeding, the baby is spitting up real time, vomiting, retching, regurgitating, ruminating on something. Well, that's when I start to think there's an upper GI issue. So there's something is happening in that upper side, it's not letting it go down. How about the other direction? I see fatty stool, we have a ton of diarrhea, something is malabsorption, there's something in that lower GI tract. And if you ever see fatty stools, what are the things that you're thinking? Yep, say it. Cystic fibrosis. You see fatty stool on an exam for your pants, you think cystic fibrosis. Fatty stool tells you that there's no pancreatic enzymes to break that fat down, sodium chloride channels. You have snoring, you have mouth breathing, you have something where the kid is making sounds like a 70-year-old man, right? That tells you there's some upper airway issue versus crackles, wheezing, rales, rhonchi. I'm aspirating, there's a lower respiratory tract issue. Or I'm having all kinds of weird infections, tons of ear infections, lung infections, skin infections, it's all over the place. Do I have an immunodeficiency that's going on? Or some sort of HIV issue? Or their travel history. They tell you that they've spent 6 months in wherever, and so you start thinking about what's endemic to those areas. Things to consider then. What do you do? So now you've identified it. You're the provider. You've identified it. You said, I am diagnosing you with this. I've gotten a good history, so I understand probably where this is coming from. What am I going to do from the labs? And this is where you will see my favorite word. My favorite word on this is the word consider. Consider is the best word for a provider that you are ever going to be able to use. It will save your butt. Because if you consider anything, you've showed your thought process, but you have not committed to ordering that. So you can, the lawyers all day, you can consider things all day, and it will show your thought process again without saying, I'm going to order this, and then you did. So consider best word for your charts. So you're going to consider these labs. This does not mean that you will get all of these. It means based on your history and physical, you're going to consider what you want to get. So am I going to get ACVC? So look at those cell lines to say, do I have an anemia? Do I think that there's a leukemia going on? Is there bruising, bleeding? Something's not right there. Am I get an iron deficiency panel? That's the most common worldwide deficiency for nutritional issues. So am I going to get that? We'll talk about that in our heme lecture. If I got a UA and a culture, because I think there's renal disease, what is the UA going to show? Yeah, protein. You're going to spill a whole bunch of protein. So if I think that and I get a UA, it's going to see some protein. If I get a CMP and it says endocrine, I'm looking at a glucose. Do I think this is a type 1 diabetes that's manifesting? The youngest I've seen that is down to about 18 months. So an 18-month-old that came in. So I could see that on a CMP. Could see some also renal disease or liver disease in my LFTs. Do I think this is infection? And I need to then really understand where the history is. Do I need to do a PPD, get HIV, some sort of stool cultures to see if what kind of parasites are going on? Always thinking, could be thyroid, if there's any kind of metabolism or metabolic issue. Celiac is a huge one. We see that all the time. It manifests in kids not like adults. It manifests oftentimes where they're just not growing because they cannot absorb. And then always thinking, do I need to check the chromosomes, especially if this is symmetric where you have head, length, and weight affected? Do I need to check those chromosomes? Do I need to go back and make sure that somebody checked that newborn screen? They might have gotten the newborn screen, but did anyone actually follow up on it to see what the results were? So things to consider of what you might want to do there. Now, I've considered all that. I've gotten the appropriate management. Who do I think would be other specialists for my team that I'm going to say, help me? Nutrition or dietetics. Yep. Who else? Potentially social work. Sure. Who else? Maybe an audiologist, depending on if there's other delays. Your pediatrician, sure. Potentially an endocrinologist. Lactation. Genetics, maybe. Missing one really big system. GI. Yep. GI. So it could be, depending on what you get, there could be a whole bunch of people on here. If you're doing outpatient, those are who I'm thinking. Do I need to get any of those friends on board? Do I need to call anybody to make sure that I'm not missing something? So I'm following them up for weight checks. We're doing very strict outpatient management of how many calories in, how many calories out. Dietitian is probably where I start most of the time. And then again, if you ever feel like they are past that point and they need hospitalization, you don't have to be shy about doing that. The calories in, most of the time you're doing 1.5 times what their recommended amount would be. So if you are just like, I love this so much, I want to figure out how to calculate pediatric nutrition, I have a whole book we can talk through that with, but ultimately it's 1.5 times more than that on average. Supplementing what's missing, so if it was iron deficiency, certainly we're going to be supplementing that, vitamin D, or any of the fat-soluble vitamins. And then again, that team approach with all kinds of people, depending on the age, depending on what's going on with the child. Okay, so we're looking at this kid. You've been following this child since birth, and you have concerns with those growth charts. You've been watching this. Which of the following helps you make the diagnosis of failure to thrive or growth faltering? The child is in that 3rd percentile for length. Child's weight is at the 85th percentile. Median weight for height. Child's length has increased and crossed 1 percentile since the last well visit. Child is 3rd percentile for weight, or the percentile has not changed from the last visit. Delta. Yeah. Why is A wrong? Yeah, so we're talking about length. So to make that first diagnosis, we're going for weight. Why is E wrong? So this is the reason that this question is not on your exam is it's a bad question because it could be E. If they hadn't gained any weight, they might have crossed 2 percentiles. You cannot tell with this information. So this is why that's not one of your test questions, but you were correct. You know that D is correct in that 3rd percentile. So E might be if I gave you the right growth chart. Okay, so that was in general. So when we think about neurotypical children, the non-genetic, non-chromosomal abnormality type children, when they come in with growth issues, that's how we are classifying them and kind of looking through things. The next section is for all of your different genetic and congenital anomalies. And this list is growing astronomically. Every single day there's a new genetic disease and you're like, I've never heard of this. What is this? These ones are your most common ones that we see. They're also the ones that you can confuse with each other, so they will have a lot of overlapping presentations. And so the PANCE loves them because they'll give you a certain set of things and be like, what is that? You're like, oh shoot. And so that's why these are easy to test. They are the most common, and so that's why we talk about them for those couple of reasons. And so I want you to knock these out of the park for your PANCE. These are what we will talk about. You guys don't have any genetics here, correct? Like, does any of your classes talk about genetics?
Yeah.
A little bit?
Briefly.
Okay. A little bit? Okay. So one thing I need you to know whenever you're studying for things in peds, when I give you percentages like that, 2 to 4% of kids, please do not spend your time memorizing that. I'm not going to test you how many percentages of kids. I'm giving you that for an epidemiological framework. Why are we talking about this, right? This is 1 in 2 bajillion. Why we wouldn't be talking about this? So we're talking about out of every 100 births, 2 to 4 kids are going to have this going on. This is why we talk about it. So don't spend time memorizing those things. It's just for context. But when I say 2 to 4% of kids, so out of 100 births, let's say 3, on average, kids are going to have some sort of chromosomal or genetic anomaly, yet those 3 make up half your hospitalizations. So you see them over and over and over and over again, right? So that's why they are a small percentage that takes up a lot of our inpatient particular health care. So you might be on your rotation for peds and see a same kid with some very rare disease 2 or 3 or 4 times on that rotation. That's pretty standard. So you could have all kinds of things where there's a whole bunch going on at the same time. You could have a chromosome that's added or deleted. You could have one gene that is has some sort of mutation. Or you could have completely normal genetics and something was introduced into that as a teratogen that makes a certain presentation form. So we'll talk about a couple of those different things. Remember when you're looking at autosomal dominant, meaning one of them is normal, but one of them is not normal, and that one not normal is enough to knock out everything. So that abnormal one is dominant and will take over, versus autosomal recessive, it takes 2 abnormals, one from mom, one from dad, to make that phenotypic expression. And then for X-linked, typically in males or typically in females? Typically in males. Why? They only have 1. So if 1 is down, probably going to have more expression. Again, do not memorize the numbers associated with it, but this is in the order that we're going to talk about them because this is in the order of how common we see them all. So we're going to talk about Down syndrome the most because we see it the most often, and then again in descending order. So we'll hit all of these anywhere from 1 in 800 to 1 in 10,000 of what we're going to see. So we said Down syndrome. Okay, that's trisomy 21. What are the other trisomies that are compatible with life? Yep, so it's trisomy 21, trisomy 13, trisomy 18. If we added one more screening test, it would give us the quad screen. What's that other test? Alpha-fetoprotein, and what is that looking for? Spina bifida. And what on exam might you see that would indicate that there's spina bifida? A tuft of hair. What else could you see? A bulge. You could actually see that coming out. What if I said there was a gluteal cleft or a gluteal fold and I couldn't see the bottom of it? What would I be ordering then? When in doubt in peds, what are you going to order? What kind of ultrasound? Spinal ultrasound. Yep. And what is probably deficient? What nutrient was probably deficient there? Folate. Okay, so that's an example of how we need to be able to think forwards and backwards with this material. To be like, what kinds of things do I need to know? So yes, perfect. So trisomy 21, we went into the Nippet screen. So that's one of the things that we are going to see from that. So you have 3 copies of 21, trisomy 21. In every single cell, you will have 3 copies of that number 21. Certainly you see that with advanced maternal aging. Yep, hold on a second. There's another way, transmission, I think there's a hidden slide in there. Don't worry about, you can have a translocation. Do not worry about that. Every single child that you think, I think this child has Down syndrome, is going to need a chromosomal analysis. When I say chromosomal analysis, what lab test is that synonymous with? A karyotype. Yep. I'm actually going to look to see, do I have 23 sets? Do I have all 46 chromosomes there? So that is what I am looking at. So chromosomal analysis, aka karyotype. So all of those are going to be needed. They will also need a referral to a genetics counselor to say what is likely going to happen over time. We said the rates increases as maternal age advances. So if we're looking at this, if you think all the way back to freshman biology in college, you remembered you had mitosis where all the cells divide and replicate. Then you had the sex chromosomes that go through meiosis. There's 2, meiosis 1, meiosis 2. So in utero, this little girl is going to have all the eggs that she's ever going to have, and they will be stuck in meiosis 2. And so they will have one last split, and when that splits, and you'll talk about this in women's health, it splits right when that follicle, that egg, is going to say, it's your month to be released. It will do its final disjunction. So if you're 25, it's been sitting there for 26 years. If you're 45, it's been sitting there for 46 years. It's more likely then to not disjoin correctly, but go together, and you'll have 3 copies then. Okay, so that advanced maternal age, that's what's happening. You have that non-disjunction from meiosis 2, more likely the longer it's been sitting there like that. The reason that I particularly bring this up is that I've seen this question get manipulated on standardized test questions. And so if you look at this, if you are 25 years old, your chances of having a baby with Down syndrome are 1 in 2,000. Compare that to if you are 45, it's 1 in 10. However, does the question ask, at a population level, who's more likely to have a baby with Down syndrome? Or does it ask at an individual level? So that population level, there's more people having babies at 25 than 45, so you're still more likely at 25 to have a baby with Down syndrome than you are at 45 because you have less people having babies. Okay, so you have to watch those questions very carefully. Is it asking if you had a 25-year-old versus a 45-year-old? The 45-year-old is more likely to have a baby with Down syndrome. If you're looking at population data, who's more likely? If you're 25. Okay? So that's the type of way that the pants can sometimes be sneaky with data. So always look, what is the question asked? When we say this person has Down syndrome, a lot of times this is one of those things where we have our eyes, there's enough times that we've seen this in society that we know somebody has Down syndrome. I can see that. But what are we really seeing? What are those facial and phenotypic things that we are seeing? So certainly when the baby comes out, they are hypotonic. So we don't see them in that high flexion state. We see them kind of almost limp. So they tend to be more in extension, have a head lag when you try to do the moro. They have a less startle reflex. So in general, hypotonic, and then kind of throughout a lifetime. In general, they have a small head. So we said that typical head from the occipital protuberance to the front of the forehead is about 35 centimeters. So you'll see a relatively small head shape at birth and then as they grow. The facial features. When we're talking about palpebral fissures, so at the very edge of your eye here, if you look at your neighbor, they should be going down. In these children, they will go up. So you have up slanting palpebral fissures. The epicanthal folds, or that part of your eye, it's pronounced as it comes over on that medial side. A flat nasal bridge, so right as it gets to the eye, right below your eye is when you should start seeing that the nose starts coming out. It will be flattened right there for a longer portion of time, so a flat nasal bridge, kind of that mid-face hypoplasia from that. We talked about the ears. They can be often low set, posteriorly rotated, and then in general very, very small. We'll get into why does that matter later. And then macroglossia, what does that mean? Large tongue. This one is actually not correct. It drives me nuts because the tongue itself is the normal size. The head is small. So proportionately, for the head size, they have a large tongue, but the tongue itself is a normal size. So we do call it macroglossia, but it's a little bit of a misnomer there. Other things that you see, so that is what you're going to see really for every child when you see those stereotypic facies, those phenotypic facies. Other things you might or might not see on the extremities. So if everyone looks at your hands, look at your hands, everyone has hand creases. They're going to look different. Typically, you will see the more creases you have, the more in utero movement you had. So we talked about that with the bottom of the feet. If you have hypotonia in utero, and because of this genetic condition, you probably have less movement overall, and that less movement can make a single transverse palmar crease. So that can be a variant of normal. So if you look down at your hand and you're like, oh, I'm just gonna put my hands away now, right? That can be a total normal variant, but you see it proportionately more in children with Down syndrome. You can also see a shortened fifth finger. So you see a picture of that there. A widened first toe space is what the other picture, if you'll sometimes hear that called the sandal sign or the flip-flop sign, potentially. And then just in general, the fingers are very short and stubby. From a developmental standpoint, we see all kinds of things. So all of these complications. So 100% of children with Down syndrome will have some sort of developmental delay. That can be a wide range. That can mean they are completely functional, they live on their own, they do incredible things, all the way to profound intellectual disability, never can live by themselves, have a lot of concurrent things going on, right? So wide spectrum, but every single child with Down syndrome will have some sort of developmental delay. Because of that ear, the small ear, there's the propensity, and we'll talk about why again, to have some hearing loss. So a ton of eye and heart issues. We're going to go through these individually. GI, metabolic issues, because if you think about this, every single cell has an additional copy of something. So a lot of things are added and then taken away. To include some skeletal issues, blood line issues, both with your white cells and your red blood cells. And so for all of these reasons, there's a whole different screening protocol that we are going to do with these kids. So piece by piece then. So if we're talking about hearing loss, so we said they have small ears, potentially posteriorly rotated and lower. So you could have sensory neural hearing loss. Truly the cochlea and cranial nerve 8 are disrupted, so they do not have the sensory neural pathways, potentially. Secondarily, because of the small ears, they have a tendency to get infected, and so you have repeated otitis media, which means you have repeated scarring. So you have a propensity for that cochlea and cranial nerve 8 to already have some issues, and now you have some scarring on there. So potentially, these children suffer from hearing loss more frequently than the typical child. So we'll talk about how often are we actually doing those hearing screens for these kids. We look at the eyes. So if you look at the iris of an eye, they will have some gray dots kind of throughout. So that's what that first picture there is showing is your brush field spots. It's just those gray dots in the iris. It doesn't hurt anything. It's just something you might notice on exam. They can be born with congenital cataracts or have a very early development of cataracts. This one's so interesting to me, and I'm going to nerd out on you here. So on chromosome 21 is your precursor for your beta amyloid. So your precursor for that eventually will make beta amyloid plaques. So if you think about beta amyloid plaques, potentially you see more of that in Alzheimer's disease. So if you're like, well, why does Down syndrome have early Alzheimer's disease? Well, they have 3 copies of that precursor. But another thing that it is a precursor to is that lens opacification. So if you have more of the precursor that's going to make your lens opaque, you are going to have early cataracts because you have those 3 copies of trisomy 21. There's also a thing during development called esometropia, And that is how does the eye form. So you have very steep corneas, and you have a refractive issue that they have from the axial side of that eye. And so they're more likely to have early and significant refractive errors. That is going to then lead to that lazy eye or strabismus because that one side is trying so hard to keep up. There's a lot of eye things going on with these kiddos with Down syndrome. So we do not just hearing checks a lot more frequently, we do a lot of vision checks on these kids to make sure they get early intervention. Oh, my favorite one, or not my favorite one, but it's just super interesting how the embryology comes down. So when we say endocardial cushion defects, did you learn that terminology from Commander DeBoer last semester? Did you hear endocardial cushion defects? Okay, so back to embryology. When we say the endocardial cushion, it's an embryologic structure. So endocardium, is that the inside or the outside? It's inside, the inside of the cart. So the endocardial cushion is what will come down and it will make your septum. And so if you have an endocardial cushion defect, you are probably going to have something that goes awry with the septum. And the septum is going to be those walls between your two atrium or your two ventricles. So you're more likely with Down syndrome to have an ASD or a VSD, something wrong with that septum because there was something wrong with your endocardial cushion that made that septum. If you have a hole there, certainly you're going to end up with that left to right shunting. So that red blood that already got oxygenated, instead of going to the body, is going to go right back to the right side of that heart. And eventually that right side of the heart, that pulmonary vasculature is going to clamp down and say, I have already oxygenated you enough. And you end up with pulmonary hypertension, and then that enlarging of the heart and heart failure from that. So those are ones, if you have a kiddo with an ASD or a VSD, we want to shut that down so that you don't have that loop going on. Early surgical management for these kids is imperative. So some things don't form, some things form incorrectly, some things form extra. So the duodenal and the GI tract, this is one of those that doesn't form correctly. And so sometimes you will have duodenal atresia. So yes, your textbook talks about esophageal atresia. I'm sure that is the case. I've never seen that. I have seen duodenal atresia. So part of the duodenum just doesn't form. And so on x-ray, you see what is the double bubble sign. So you see that air gets into the stomach. That's bubble 1. Air then goes into the proximal part of the duodenum. That's bubble 2. And then nothing else because it's atretic. There's no outflow tract. So you have these 2 bubbles, then nothing. If you see 2 bubbles of air like that, the double bubble sign, it is duodenal atresia until proven otherwise, and you think to yourself, does this child have Down syndrome? That is going to require surgical treatment because there is no outflow tract. If you are missing part of your intestines, you do not have a continuous loop then. Atlantoaxial instability. So that is between C1 and C2. If you have that, you have an increased distance between C1 and C2, so they can slide amongst each other. So you have more likely that instability and that you are going to have a spinal cord injury from that. So when I came out of training, we used to do x-rays for every kid with Down syndrome every single year. And do you know what that did for us? Nothing, right? These kids were walking around doing their thing every day, totally fine. So we really weren't picking anything up. So now the recommendation is if they're going to be putting themselves in a position where they are going to have more pressure on that neck, certainly let's get a baseline set of x-rays, but we don't need to just irradiate these kids every single year. So the classic thing that you might see on a question is a child with Down syndrome wants to do gymnastics. What do you need to do before they start gymnastics? So x-rays are going to be what you see for that. Okay, so this is where I went a little crazy with rebolding and underlining. I don't really know why. Actually, I do know why. I'll tell you why. So these are the things, okay, so a baby comes out, you're doing that neonatal newborn care, and you're starting to do your exam, you're looking at that baby and you think, this baby I think has Down syndrome, so what am I going to do? So what I did is I underlined any kind of test or lab you need to do and bolded any kind of referral you need to make. That somehow made sense to me at like midnight last night. So, what are we doing? We're getting a karyotype. I want to see, do I have extra chromosomes? Do I have that extra copy of that chromosome, or do I just think that I do? Right? So a karyotype for every single baby, right up here on the board. I need to do a hearing screen just like I would for every baby, but I also need to do a follow-up hearing screen at 6 months. So not just that one and done, but another one again at 6 months. I worry about the endocardial cushion defect in a VSD or an ASD, so I need to have pediatric cardiology on board for an echo. I need to see, does that heart have something wrong with it? What I have seen some providers do, and even pediatricians do, is they'll have a normal echo, and they will say, well, they need to continue with cardiology forever. But why? You've already checked the heart. The heart is normal. You're not going to, like, people will be like, oh, I don't know, maybe they're gonna like pop a VSD. You're not gonna pop a VSD. That's not how physiology works, okay? So if you have normal plumbing, you have normal plumbing. You don't need any cardiology follow-up after that. For all the reasons with the eye, those refractive errors, early cataracts, strabismus, ophthalmology by at least 6 months. And then for labs, I need a baseline CBC because they are likely to have those cell lines be abnormal. So a baseline CBC, a baseline thyroid, and a free T4. So both at birth and 6 months. I need the newborn screen like normal, and then these kids get those standard immunizations. This is in now, you're outside that newborn period, you're outside of those things that you did at birth plus 6 months. These are all of the other things that you need to do. So every time this kid comes in for a well visit, so those annual visits after the age of 3, making sure that they had the hearing screen at birth, again by 6 months, and then they start getting annual screens. So you're checking those ears every single year. So you're not checking every kid's ears every year, but a hearing screen every single year to see, do they have this chronic scarring or sensory neural defects? Ophthalmology, these kids are seen annually, so they have audiology and ophthalmology on board. For sleep medicine, you start asking about snoring because they will have these enlarged adenoids relative to their small head. So again, the adenoids are not the problem, the head size is. And then they will all need a sleep study between the age of 3 and 4. They will start early intervention services, so it's a federal program that is in all 50 states and then territories that we have. It says early home PTOT and speech therapy. And then plus or minus different specialties depending on what you find. So if they do have these early and frequent and sensory neural hearing loss, they're gonna need ENT. If they have a hole, they're going to need cardiology. If they don't have those things, you don't need those. If those risk factors exist, they're going to be doing gymnastics or horseback riding. That's another one that I see. If you're pressure on your neck like that, we'll do C-spine or C-spine x-rays. Those annual labs then, so you had your baseline for the CBC and thyroid. So it's an annual TSH to check for that thyroid, an annual CBC, and annual iron studies. They have annual celiac questions. So you are not necessarily going to add that with the labs when you're poking, but you're asking questions, and if something is wrong with that, then you are adding that panel. And then your regular immunizations. Let's take, actually let me finish one slide and we'll go. So the thing that is going to determine how long and how well they do is the heart. So it might not be the problem right away, but their long-term lifespan is determined by that cardiac. So the ones that have congenital heart disease are more likely to survive up until the age of young adulthood. The ones that do not have an ASD or a VSD, more likely to survive double that. So your cardiac is really what's gonna determine your long-term outcome with Down syndrome. So there's checklists, so I need you to know these things for the test, but in real life, I look these up as well when I have a kid that comes in for their well visit. So let's stop here. We'll pick back up at 11 with alcohol. So we got through Down syndrome, did all of those things. So be aware of some of those different screening things and how that differs from the normal, typical child that you would do screening for every healthy child. The next one that we're going to talk about is fetal alcohol syndrome. And so this one, the way I see in this one, get people on standardized tests is, let's say, what's the most preventable developmental delay? And so this is one of those teratogens, right? If they had normal genetics and you didn't ever introduce alcohol into this, you would have no problems. So that's why it's the most preventable one, right? So just kind of, again, watch for what is the question asking. You do see this in lower socioeconomic areas or higher end American Indians or higher end foster care makes sense that you would potentially have some of those other social determinants of health and some of those other concurrent problems. Makes it more likely that this is going to be something that we see. The other big thing to know about this is there is no lab test that I can do that says this is what this is. It is a full clinical diagnosis because their genetics are normal. This is then a phenotypic expression of those genetics once that alcohol was introduced there. So what are those typical features that we will see? Well, number one, oftentimes they're very small or smaller children. Some of the facial fissures, so short palpebral fissures. So remember I said they overlap sometimes, so they're not upslanting palpebral fissures, they're short palpebral fissures and a short length. So this one I think is kind of hard to see. We'll look at some pictures, but it's the distance between the eyes is relatively shorter. So they kind of have rounder eyes is the way to think about that. The two that I think are the most common that you see. So everyone, if you take your finger and you go right across your upper lip, you should feel the double ridge there, your philtrum. This is what kids don't have. It is completely smooth. So you're like, that is really unique. We don't see that in anything else. So the smooth philtrum. And then if you think about, if you have nieces, nephews, if you have children, you see these little toddlers, they have like Kim Kardashian lips, right? They have like the most voluptuous little lips in these toddler age kids. These kiddos, you can barely see that thin upper lip. So those are the two things that when you're doing an exam, you're like, those are different. That's particularly different. They still have some of that flattened mid-face. That's something you see pretty common, a very short kind of upturned nose sometimes. The ears, with the railroad track ears, that's what that picture up there is saying, is there's kind of an extra fold that you will see along inside of that ear. That extra fold looks like a railroad track. Sometimes you'll see some ptosis. Sometimes you'll see microcephaly, so you might also see a small head, micronaphia, or a small jaw. And then again, the epicanthal fold. So you can see how, if you see just those words, you're like, I saw those words with Down syndrome, but now I'm seeing them here. So making sure you can distinguish. The same thing, just on a picture, so that short, small palpebral fissural length, your epicanthal folds that are prominent, your railroad track, your nose, but most of the time your smooth philtrum and your thin upper lip is what you're looking for. So if you look at these actual kiddos, I think it's really hard to tell the eyes. You can't really see the ears. It's hard to see the mid-face hypoplasia. But on all of these kids, you're like, that's smooth, and I see no upper lip. Teeny, teeny, tiny upper lip. So that is what I want you to be able to pick out on a picture for these kids. And also given some of the same words, you see that. A few of the other things that you might see. So instead of having a short fifth finger, you could have a curved fifth finger or a clinodactyly. Instead of having a transverse palmar crease that you saw with Down syndrome, you might have a hockey stick crease that looks pretty pronounced, where it's kind of got a right angle of that crease. Same cardiac anomalies, so from a different reason. So if you think about, and I think this is kind of interesting, I'm going to nerd out for a second on you. When you had kids that have hokum, or adults, and they have that really, really large septum, one of the old treatments they used to do was they would inject the septum with alcohol, and ethanol alcohol would actually help decrease because it kind of kills off those cells. So if you think about what's happening with a normal heart, you introduce alcohol to it, it's going to destroy part of that septum. So very different reason from the kids with Down syndrome having ASD or VSD, but they will both present with that alcohol. And then what I need you to star is the developmental abnormality. And that's typically how it gets picked up. This kid goes to school, they're 5, 6, 7 years old, they're having trouble with handwriting, they're having trouble learning their letters, they're having trouble reading, they're having trouble sitting still. Something is going on behaviorally, and they get referred to the pediatrician or to the primary care PA, and all of a sudden you're doing your exam and you're like, ooh, smooth philtrum, thin upper lip. Some of these facial features, I think this is fetal alcohol syndrome. So your developmental delay is much more likely to pick things up than all the rest of those other things combined. So what are we trying to do? Well, since it's preventable, we want to prevent as much as we can. That's why we do a lot of counseling with those high-risk teenagers who could get pregnant, with those young moms. That's why you're going to do a whole bunch of alcohol education. with young soldiers, airmen, sailors, Marines, coasties, guardians, all the things. And so are you guys guardians? Did I make that up?
What?
Are you guys guardians?
Space Force.
No, you're coasties. You're just coasties. Okay, coasties. Okay. One semester I looked and there was a Marine, and I was like, what are you guys called? And he was like, Marines. I was like, oh, yeah, and I felt really stupid. Okay, so you're trying to go, certainly you see this as a risk factor if there is more than 7 drinks a week. That makes sense. If there is constant infusion of alcohol every single day, more likely to see this. More likely to see this if you are at an amount more than 3, where you are feeling the effects. If you're feeling the effects as a mom, you know it's crossing over to the placenta and the baby is getting those effects as well. Again, it's a multidisciplinary team. If that's an answer in a pediatric question, that's probably the right answer. There's always multidisciplinary teams, so that's a pretty good one most of the time, because you're going to have the school involved, you're going to have the family involved, different types of therapy, maybe occupational therapy or speech therapy, and then potentially medications involved. So, okay, so that's yes, ma'am.
Is there a gestational age where this is more dangerous than others across the board?
Yeah, no, that's a great question. Is there a gestational age where it's more or less prevalent? So if you see this younger, the younger that you are, oftentimes that will result in a spontaneous abortion, where the baby just can't survive, and so you kind of see it in the middle. You could see it. There's no like this particular set of weeks that some infections are, but certainly kind of after all the organs are there and they're getting bigger. Kind of a happy. Okay, Fragile X. This one is super interesting to me as well, because I say that to everything, Tom. They're all super interesting to me. They kind of are. So this one, you see the edge of one of the chromosomes has a whole bunch of extra CGGs. So those extra genetic material makes that one side of the X much longer. And so on a karyotype, if you're looking at it, that X looks like it's falling over because it has one side that has all those extra CGGs. So it's not that the X is actually fragile, it's that it looks like it's gonna fall over on a karyotype. So that's why it's called that. Fragile X then is one of the genetic reasons that we see intellectual disability. It's also one of the genetic reasons for autism. So if we say, we don't know that, and it certainly doesn't cause all autism, but certain types of autism are caused directly by Fragile X. So we do see that. You do see all kinds of behavioral abnormalities with this. So you can see anything from their hyperarousable to emotional instability, to anxiety, agitation, all the way to that profound intellectual disability or autism. When you see that on the end of the spectrum, so you will see hand flapping sometimes, or even seizure-like activity going on in the brain. This one, instead of having a small head, you see a very large head. So this is the exact opposite. Large head, large jaw, large ears. So we said Down syndrome had small head, small ears. We said fetal alcohol syndrome had a small head, small jaw. We said Fragile X has large head, large ears, large jaw. They also have incredibly large testicles, so post-pubertal, so very, very large, abnormally large testicles. Some joint laxity, and then again with some of the hypotonia, so that also was seen with Down syndrome. There is a female variant of this, but if they have multiple X's involved. You will do DNA amplification. And the reason you'll do that is because the karyotype, you might see that the X is kind of looking fragile there, but without seeing those repetitive CGGs, it's really hard to tell if that's what's going on. So DNA amplification. And then again, your multidisciplinary treatment. So school, your developmentalists, your therapies, parents, pediatricians, everyone's on board. Certainly if you have seizures, neurology is on board for that seizure control as well. Okay, then you're gonna get into Turner syndrome, where you start into, you've seen some of my pet peeves already. This is one of them for whatever reason. So it's not Turner's syndrome, it's Turner syndrome. The other thing that you see is there is no such thing as an O chromosome. It's really just 45X, right? There's no O, but you will see it forever through the rest of your career written as 45XO. It's just 45X. So now, hopefully you can be bothered alongside me for my career. And none of you probably will ever care, but it matters to me. Okay, Turner syndrome, 45X. They're missing a whole X. So functionally, what I need you to think about that, yes, there's mosaicism, yes, they have some abnormalities. For our purposes, they're missing an X. So they just have one. And what oftentimes that means is that they went into early ovarian dysgenesis. So they don't have both sets of X's that make the ovaries do what normal ovaries are going to do. So early ovarian dysgenesis, the way to think about these little kiddos is that they went through menopause early. So they come out to you as these little kiddos already gone through menopause. So you're treating them as such and kind of replacing those things that you would have lost in menopause. So what does that look like then? They come out really, really short. So short kids, a webbed neck. So if you look at your own neck or a picture of the person next to you, your neck is, it should be, smaller than the size of your head. Certainly if you have super large traps, you might have a little bit of that, but your neck should be a little bit smaller than the width of your head. In a lot of these kiddos, it is the same. It kind of just comes out with a webbed neck like that. When we talk about the shield chest, so if you're doing a physical exam of a kiddo, you should look at their earlobes. The earlobes are right in line with the nipple line. If you're looking at the earlobes and the nipples are wide spaced, that is how you are looking at a shield chest, those wide spaced nipples. And then because of the webbed neck, you often see that triangle faces. Neonates will have a specific presentation sometimes, not all the time, but they have a lymphatic drainage issue. And so these neonates will be born in the NICU. Sometimes you'll see it with this lymphedema, and that's what that picture down there is showing you, is the lymphedema from this lymphatic malformation that you see that is sometimes present. However, so when you think about this, if you're looking at the genetics of this, they're missing that whole chromosome and their ovaries are not able to do the normal ovary things. 95% of these babies are spontaneously aborted in utero. So most of them don't ever make it to the point where they are compatible with life. The 5% that make it are incredible little humans, and so they have often even superior intelligence, superior verbal skills, superior in school presentation, which is oftentimes then why they're not picked up, because they do so well in so many other parts of life that it's not until they come with infertility or they didn't go through puberty that you start seeing some of these things. So what are the things that we might be seeing? Well, when you have this kind of lack of estrogen, this is kind of the way I think about it, you are at risk for some of these early heart things. So what does that look like particularly for these kids? It can look like coarctation, so that coarc, where it's stenosis, so that coarctation of the aorta, or they have a bicuspid aortic valve. Just went to a conference last weekend, and just of note for your adult population, I didn't know this, if you have an adult that has a bicuspid aortic valve, every single first degree relative is supposed to be screened. I didn't know that. Anyway, this screen. The second thing, and probably the most common reason that they come in, is that they will have amenorrhea or infertility. So they come in, and now you have this 13-year-old, and all of her friends have started their period. Everyone's wearing a bra. Everybody is starting to shave their legs, but she just still looks like she's 9, right? So you have this they don't start fertility because their ovaries are just sad, just little puny one little ovaries that have kind of already functionally had dysgenesis. And so they look like they've already gone through menopause, okay? But they're these little kids that just haven't gone through puberty yet. So that amenorrhea, if they do have some ovarian function, they will sometimes then kind of have what is sort of a new normal puberty. They'll get married, or be in a relationship, want to have a child, and then they'll come in for infertility. So we can see that as well. Some of the renal anomalies, you might have one kidney that doesn't form, or they have just one kidney in general, and they have a horseshoe kidney. And then again, very short. And then when you think of those menopause type things, osteoporosis, because they don't have that estrogen helping with that development. And then again, hypothyroidism, because that goes with everything. Yeah. Your diagnosis, again, a chromosomal analysis or a karyotype. You will have 45 instead of 46 chromosomes. They will need endocrinology for a couple things. Number one, we want these kids that are tall enough to be able to push down on the gas pedals and see over the wheel. We want them to be able to come to normal counter heights and just live a normal life at a normal size. So they will often get growth hormone to help with that. Then they will get estrogen replacement to help with some of the bone density, any type of fertility potentially, normal development, and then thyroid replacement. So endocrine is some of the biggest one that we do on board. Cardiac will be big to see, do they have that coarctation or a partial coarctation, or do they have that bicuspid valve? And then a renal ultrasound. Anything wrong with their kidneys. So we're checking the heart, checking the kidneys, and the endocrinology for sure. What about the exact opposite? Instead of a little girl missing a chromosome, you have a little boy that has an extra chromosome. So he got that extra X. So they have a little boy, XXY, 47 XXY, Klinefelter syndrome. So in this, they typically will look normal prior to puberty. There will sometimes have a very, very small penis that you'll see a micro penis, but not all the time. Sometimes they will have normal intellect. Sometimes you will see some intellectual disabilities or delays. So thinking similar in that Turner syndrome, you are thinking about this as a testosterone deficiency. So the way I think about it is that extra X is preventing the Y from being able to fully express itself. So they're in competition. So you end up with this testosterone deficiency overall. So you see this hypogonadism, so small gonads is primary, meaning it's the organ itself. So those testicles are having some trouble. They're infertile because specifically from the seminiferous tubule. So it's not that they don't make sperm, it's that they can't get the sperm out. Because they have this proportional extra estrogen, they're going to have gynecomastia, which makes them more at risk for breast cancer than the typical male. So it's something to screen for later. You'll see a diminished hair pattern in general, again, because that extra estrogen. It's more of a feminine build, so a little bit wider hips. And then in general, you'll see a lower IQ in these males. Again, your chromosomal analysis. So you're looking, it'll be 47 instead of 46. On your labs, you will have increased LH and FSH. That pituitary is normal. The pituitary is saying, hey, I need more testosterone, I need more testosterone. So those are high, but the organ itself is low, so low free testosterone. Endocrinology is still on board, and they will say, let's give that extra testosterone. So they are giving that, and they will also help with some of the potential for fertility. So they make sperm, but we got to get the sperm out. So there's ways to extract sperm. One of the things I think that's really interesting is that it's not, every single Klinefelter's is a sporadic disease, so it is not genetically passed on. So it's not something that you have to worry about with that. And I already said the breast cancer thing. You will sometimes see this picked up at MEPS. You'll sometimes see this not picked up at MEPS. And you will see these families that will come in because they want to have a child, and there is one of the reasons for male infertility. So I've seen this with a airman who'd been in for like 17 years, and they were coming in for infertility, and the workup was, hey, you've had Klinefelters your whole life. So you do see this some of the time. You will see some of these present in your adult medicine clinics, not with me. So it's something that you might see. Something to think about if you have infertility in a male. Marfan syndrome. I love this one. So this is another thing I'm not going to ask you. I'm not going to ask you, this is a mutation of fibrillin 1 on chromosome 15. That's a waste of a test question. That is a random factoid, right? There's other factoids I need you to remember, such as like, at what age are you screening for anemia? Like, those are the factoids I need you to know because it affects practice. This is interesting knowledge. But I'm not going to test you on that. So if you think about what is fibrillin, so it is part of that connective tissue, but it's specifically part of the connective tissue that makes elastin, or things that are elastic. So anything where there is stretchiness in your body is going to have a problem. There's going to be more stretchy, more hypermobile. Skeletal, cardiovascular, and eye. Lots of stretchiness there. A lot of stretchy in the eye, a lot of stretchy in the heart and in the vasculature, a lot of stretchy in your muscles. So those are the places that you are typically going to see things. Because it is autosomal dominant, it's not male-female, has no race predominance. So you can see this equally, males and females. So the biggest thing that we worry about is that aortic root dilation. Why? Because it's got a lot of elastic there and there's a high pressure there. So you're more likely to have some sort of aortic root dilation. That then if you get more pressure to that, more likely that you're going to see an aortic dissection. So that is the thing that we always worry about and screen for and make sure that's not going to happen. The other thing you see, since it's skeletal muscle and some other things, you see really long ratios. So if you put your hands out, my wingspan should not be wider than I am tall. Certainly not at all, real short here. But they will, so their wingspan will be more than they are tall. The other way to look at this, when you see pictures, if you're like, what is that? They have really short little bodies here and a lot of limb. So there's a lot of arm, there's a lot of leg. Not a whole lot of that mid thorax. You also will have some of these different thumb signs, wrist signs, and because I think of that as not a whole lot of body in the middle, there's some scoliosis. Right? They kind of outgrew their spine, or they not at all, it doesn't all fit. So they have to squish all that spine in that small little area. Because it's all squished, you can see a pectus carinatum or a pectus excavatum, so it's pretty common. And then all the stretchy in the eye, you can see those lens dislocates as well. So let's do some of these. So can anyone, so if you take your wrist, can you take your finger and straight back? Can you get it to the back of your hand back here? That's sign 1. Okay, nobody got that? How about this? We usually get a couple. Can you take this thumb down here and touch your wrist? Got that? No? Okay. What about if you put your thumb through your fingers, does a whole joint come out the other side? So it's not just that you see a little bit of your thumb, you need to see a whole joint come out. No. And then if you wrap your wrist around, does it go a whole knuckle? Those are some of the kind of quick tests that you can do in clinic to see if there's some hypermobility or some of that increased length, right? If that was you, there's a whole test that we can go down afterwards. I had that one student one semester was like, oh my God, I could do 2 of those. Did not have markings. Had some flexibility there. Here's that pectus excavatum or carinatum. So you have some sort of skeletal abnormality, some kyphosis or some scoliosis going on. And then here's those example of what I was trying to show you, right? There's a lot of limb, a lot of arms, a lot of legs, not a lot of mid-thorax and mid-body. Your diagnosis, it was not with a karyotype because this is not a whole chromosome. This is just one part. So a FISH examination, a fluoro in situ hybridization, where we're putting a dye to see is there one chromosome that lines up that is abnormal. So that is what we were doing at FISH. We want cardiology on board because we need that echo. We need to see, is that pressure causing any of that aortic root dilations? And potentially, do we need any kind of endocarditis prophylaxis? I'm not saying they do, just that is a potential. Here's what I really need you to know. You see this kid. You know they have Marfan's. You know they're at risk for that aortic root and that high pressure. So we want them to do sports and stay active, but we want them to do sports and stay active with things that are not going to have all of a sudden a huge increase in that pressure, right? So things where there's that sudden increase, like weightlifting, anything. So this is the person in active duty you don't want as your fighter pilot. They're going to be pulling G's, right? You don't want that with this potential, with this aortic root. This is the kid I don't want on roller coasters, where all of a sudden you're going upside down and you're having that increased pressure on that aortic root. This is the kid I want in golf. This is the kid I want in archery, on the bowling team, playing badminton. This is the one I want maybe even on cross country or swimming, where there's a long period of warm-up and sustained cardiac activity, not that sudden risk of weightlifting, where there's a bunch of pressure. They're also followed by not just cardiology, but oftentimes ortho for severe scoliosis, and then ophthalmology for any of those eye concerns. Most of these kiddos will again have early issues with eye from the elasticity that is there. Just a couple more and we are rounding it off onto the finish line. So DeGeorge syndrome. The other name for it, and if this is easier for you to remember, will be called catch-22. Again, this is another one of those single gene deletions. And the reason that we call it catch-22 is that it's at 22q11.2 on this. So on chromosome 22 at 11.2. So I needed to know that for me. If that helps you, great. If not, what I need you to take away from that is that specific point in chromosome 22 is responsible for a lot of midline structures. So embryologically, anything that is going to develop right along the midline of this body is what is typically affected in this child. So right in the middle is your heart. So they have all various kinds of cardiac abnormalities. So this child is going to need an echo to see what's going on with the plumbing. Abnormal faces, that's right in the middle. So stuff's gonna happen with the face that you're like, and it can come in various shapes or sizes, so that's why we're not going through specifics of that. Your thymus is right in the middle. So sometimes they have an abnormal thymus or even no thymus. So they do not have, they have a primary immunodeficiency because they don't have those thymus structures. Potentially a cleft lip or a cleft palate, again, midline. And then hypocalcemia, so it's specific to know because they are missing some of their parathyroids that are midline as well. So low calcium in a kid that has midline defects is what you're going to associate with DeGeorge. Contrast this to Williams. So that's why they are back to back, because this is a child that again has one single chromosome abnormality. So this is on 7-11.2. So instead of 22-11.2, it's on 7-11.2. Again, I'm not going to test you on that, but just this is where the pants will try to trip you up. Very short kid, and this is the ones that we call Elfian facies or a cocktail personality. A child with Williams syndrome, you will never meet a sweeter child. This is the kid and the person you want in every waiting room. You can't wait till they come. They're hugging everyone. They're so happy. They're like these little elves. They're just so happy, right? Williams syndrome is cocktail personality. They're just so happy all the time. So that's one of the ways to think about Williams syndrome. The other thing that they have, so two things that I need you to just associate with this, is they have hypercalcemia. So based on their genetic abnormality, hyper as opposed to hypo. Hypercalcemia. And that extra calcium can go sit on that aortic vessel and cause supravalvular, on top of the valve, aortic stenosis. That's really the only thing that's going to cause that in kids. So if you see ever supravalvular aortic stenosis, they're trying to tell you this kid has Williams syndrome. So if you have a kid with short stature, Elfian-like faces with supravalvular aortic stenosis, what electrolyte abnormality are you likely to see? You're like, oh my gosh, it can only be hypercalcemia because this is a kid with Williams. And then last but not least, I think this is last, Prader-Willi syndrome. So we didn't mention this earlier. We said there was autosomal dominant. We said there's autosomal recessive X-linked. There's all these different ways of transmission. Well, imprinting is another type of disorder. So imprinting, it depends on which parent you got this from. So if you got this from mom, it's going to look one way. If you got it from dad, it's going to look different. So this one, its counterpart is something called Angelman syndrome. And that is not what is asked on the pants, so we don't have to worry about that. But this one is an imprinting syndrome. And it is a really weird one because this kid comes out neonatal hypotonia. So this child is super floppy. They really have some growth delays. They can't gain weight. You end up with an OG tube where you're feeding them. You're trying to get them to gain weight. They're failure to thrive. You're just spinning your wheels. And then something switches. And then they get this ferocious appetite to the point where you cannot get them to stop eating. So kids with Prader-Willi syndrome, these families will have locks on the refrigerator. They'll have locks on the pantry because otherwise these kids will go from a hypotonic failure to thrive baby to hundreds and thousands of pounds. So absolutely do not have the mechanism to stop eating. So that is one of the things that you see with Prader-Willi. You also see a hypogonadotropal hypogonadism. So there's some endocrine abnormalities as well, some developmental issues, real small hands and feet. So that's really the only thing that stays small from these kiddos from the time that they were infants. And then slightly almond-shaped eyes. So you can see how this one gets kind of put potentially with Down syndrome because they were hypotonic. They had some eye shape. They had failure to thrive at birth, but then they switch and there's complete, absolute wild obesity from this voracious appetite. So interesting that it's completely different from a baby to a younger child. Okay, a couple of these. 3-year-old adoptive male, adopted a parent, or 3-year-old male brought in by adoptive parents. If you ever see that on a question of mine or anybody else's, they're trying to say, hey, there was something that could have been prevented or caught from birth. So anything from vaccines or something that would have been picked up on an ultrasound or something genetic. So 3-year-old brought in by adoptive parents for a well child check. Family history is unknown. Which of the following physical exam findings would be a diagnosis for fetal alcohol syndrome? So your smooth philtrum, yes. Who had the upslanting palpebral fissures? Down syndrome, yep. Who had small for age testes? Yep, Klinefelter's or potentially Prader-Willi as well. Who had breast development? Inappropriate breast development. Klinefelter's again. And then the last one's not fair. Hemihypertrophy. We didn't even talk about that completely. That's not fair. Okay. Questions, comments, concerns, anxieties, frustrations, rejections, toxicities, griefs, anything? Cool. 15 minutes early. Time to lunch.